Section 1. Anatomy I Congenital. Normal anatomy. The normal adult kidney is shaped like a bean, with a smooth, often lobulated, outer border. The kidney is surrounded by a thick capsule outlined by echogenic perirenal fat. This echogenic fat is contiguous with the renal sinus, filling the middle of the kidney. The cortex extends centrally into the middle of the kidney, separated by slightly less echogenic medullary pyramids. The normal kidney should be between 9 cm and 15 cm in length. Papilla, tip of medulla projecting into calyx. The echogenicity of the kidney should be equal to or slightly less than the liver and spleen. If the renal echogenicity is greater than the liver, this indicates some impaired renal function, medical renal disease. Liver echogenicity greater than the kidney indicates a fatty liver. Variant anatomy. Fetal lobulation. The fetal kidneys are subdivided into lobes that are separated with grooves. Sometimes this lobulation persists into adult life. The question is always: fetal lobulation versus scarring. Fetal lobulation. Renal scarring. Lobulation equals renal surface indentations overlie the space between the pyramids. Indentations between pyramids. Indentations over pyramids. Scarring equals renal surface indentations overlie the medullary pyramids. Dromedary hump. Focal bulge on the left kidney, which forms as the result of adaptation to the adjacent spleen. 180. Prominent, or hypertrophied, column of Bertin. Normal variant, in which hypertrophied cortical tissue located between the pyramids results in splaying of the sinus. Other than the hypertrophy, it looks totally normal. It will enhance the same as adjacent parenchyma. Most likely to be shown on ultrasound, looks like a big echogenic cortex. On CT or MR it would be too easy. Prominent column of Bertin. Renal agenesis. Congenital absence of one or both kidneys. If it's unilateral, this can be asymptomatic. If it's bilateral, think about the Potter sequence. When it's unilateral, it's usually sporadic, but for the purpose of multiple choice, think about associated GYN anomalies in women. 70% of women with unilateral renal agenesis have associated genital anomalies. Unicornuate uterus. With regard to men, 20% with renal agenesis have absence of the ipsilateral epididymis and vas deferens, or an ipsilateral seminal vesicle cyst. Associations: ipsilateral seminal vesicle cysts, absent ipsilateral ureter, absent ipsilateral hemitrigone, and absent ipsi.lateral vas deferens. Potter sequence, insult, maybe ACE inhibitors, equals kidneys don't form. If kidneys don't form, you can't make piss. If you can't make piss, you can't develop lungs, pulmonary hypoplasia. O.M. Ehrlich-Kustanski-Kusterhauser. Mullerian duct anomalies including absence or atresia of the uterus. Associated with unilateral renal agenesis. A lying down adrenal or pancake adrenal sign describes the elongated appearance of the adrenal not normally molded by the adjacent kidney. It can be used to differentiate surgically absent versus congenitally absent. Horseshoe kidney. This is the most common fusion anomaly. The kidney gets hung up on the IMA. Complications include traumatic injury, gets crushed against vertebral body, UPJ obstruction, recurrent infection, recurrent stones, Wilms tumor, 8x higher, TCC, from all those infections. A rare situation, but known association, is the renal carcinoid occurring in horseshoe kidney. Turner's syndrome is a classically tested association. Crossed fused renal ectopia. One kidney comes across the midline and fuses with the other. The ectopic kidney is inferior. The left kidney more commonly crosses. Complications include stones, infection, and hydronephrosis, 50%. 181. SEC 110N2 renal masses. Renal cell carcinoma. The most common primary renal malignancy. RCC till proven otherwise. A. Enhances with contrast. 15 B. Calcifications in a fatty mass. Risk factors include tobacco use, syndromes like VHL, chronic dialysis, 3 years, family history. These dudes make hypervascular mets. Their AL weighs lytic when they met to the bones. Pseudo-enhancement, a less than 10 HU increase in attenuation is considered within the technical limits of the study, and is not considered to represent enhancement. More rare once a cyst is larger than L.5 cm. Can RCC have fat in it? Oh yeah, for sure, especially clear cell. This leads to the potential sneaky situation of a fat-containing lesion in the liver, which can be a RCC met. Now to make this work they'd have to tell you the patient had RCC, or show you one. A helpful hint is that RCCs with macroscopic fat nearly always have some calcification/ossification, if they don't it's probably an AML. Subtypes, clear cell most common subtype. This is the one that is associated with VHL. It is typically more aggressive than papillary, and will enhance equal to the cortex on corticomedullary phase. Papillary, this is the second most common type. It is usually less aggressive than clear cell. More rare subtypes can be very aggressive. They are less vascular, and will not enhance equal to the cortex on corticomedullary phase. They also are in the classic T2 dark differential, along with lipid poor AML, and hemorrhagic cyst. Medullary associated with sickle cell trait. It's highly aggressive, and usually large, and already metastasized at the time of diagnosis. Patients are usually younger. Chromophobe, all you need to know is that it's associated with Birt-Hogg-Dubé. Conventional RCC staging. Stage 1. Limited low kidney and 7 cm S1 age 2, limited to kidney, but greater than 7 cm stage 3, still inside garrula S fascia A, renal vein invaded B, IVC below diaphragm C, IVC above diaphragm stage 4, beyond garrota fascica ipsilateral adrenal. Subtype syndrome I association. Clear cell von Hippel-Lindau. Papillary hereditary papillary renal care MO ma chromophobe Birt-Hogg-Dubé _ medullary sickle cell trait. Timing nephrogram phase, 82nd, equals most sensitive for detection of RCC. 182. Sneaky move. Does adult polycystic kidney disease increase your risk for RCC? Well, no, but sorta. The genetic syndrome does not intrinsically increase your risk. Hiv dialysis does. Who gets dialysis? People with ADPKD. It would be such a crap way to ask a question BW could happen. Or if you are asked, I'm recommending you say no to the increased risk, unless the Queslian writer specifies that the patient is on dialysis. Renal masses that are not RCC. Renal lymphoma. This can literally look like anything. Having said that, the most common appearance is bilateral, enlarged kidneys, with small, low attenuation cortically based solid nodules or masses. A solitary mass is seen in about 1/4 of the cases. Trivia: out of all the renal masses, lymphoma is the most likely to preserve the normal reniform shape. Renal leukemia. The kidney is the most common visceral organ involved. Typically the kidneys are smooth and enlarged. Hypodense lesions are cortically based only, with little if any involvement of the medulla. Angiomyolipoma, AML, this is the most common benign tumor of the kidney. Almost always, 95%, of them have macroscopic fat, and this is the defining feature. They are usually incidental, in the real world. The things to know about them are, 1. They are associated with tubular sclerosis. 2. They can bleed if they get big enough, greater than 4 centimeters. It's controversial if they grow or bleed more in pregnancy. Pregnancy, if they ask you, I guess you should say yes, because that's the old knowledge, but some modern papers are saying not for sure. 3. They should never have calcifications, that's probably a RCC. 4. They can be lipid poor, about 5% are, and those are T2 dark. Gamesmanship, traditional spectral fat sat or in and out of phase, India Inc., can be used to suggest an AML. Just remember rarely RCCs can have fat. Fat with calcifications equals RCC, fat with no calcifications equals probably AML. 183. Oncocytoma. This is the second most common benign tumor, after AML. It looks a lot like a RCC, but has a central scar 33% of the time, and 100% of the time on multiple choice. There will be no malignant features, such as vessel infiltration. They cannot be distinguished from RCC on imaging, and must be treated as RCC till proven otherwise. If they want to ask about an oncocytoma, they can show it 3 ways. 1. Solid mass with central scar CT, or MRI. 2. On ultrasound spoke will vascular pattern. 3. On PET CT it will be hotter than the surrounding renal cortex. Gamesmanship. I have encountered 2 types of GU radiologists in my life. Life. The first type is the practical type. She doesn't ever even mention oncocytoma, because enhancing renal masses have to come out. Even if you biopsy it and get oncocytes, it doesn't matter, because RCCs can have oncocytic features. The second type is more of your classic academic type. To try and sound impressive, this person will often include this, and other rare entities, in the differential. Another common psychopathology in these types is excessive word Nazism. Don't say that, say this. Am fairly certain you have met this person. There is usually one in every section. So if you are shown an enhancing renal mass with a central scar, how do you decide if it's a RCC or an oncocytoma? The way to figure it out is simple. Just read the mind of the person who wrote the question. If it's a practical type, then all enhancing renal masses are RCC till proven otherwise. If it's the academic type, then central scar equals oncocytoma. You may also think, which of these two people is more likely to volunteer to write board questions? Trivia: a syndrome associated with bilateral oncocytomas is Birt-Hogg-Dubé. They also get chromophobe RCC. Multilocular cystic nephroma, non-communicating, fluid-filled locules, surrounded by thick fibrous capsule. By definition, these things are characterized by the absence of a solid component, or necrosis. Buzzword is protrudes into the renal pelvis. The question is likely the bimodal occurrence, for year old boys, and 40-year-old women. I like to think of this as the Michael Jackson lesion. It loves young boys and middle-aged women. The pet trick. RCC is typically colder than surrounding renal parenchyma on PET. Oncocytoma is typically hotter than surrounding renal parenchyma on PET. 184. SECR10N3. Cystic disease. Bosnia. Bosniak cyst classification. Class 1, simple less than 15 HU with no enhancement. Class 2, hyperdense, less than 3 cm. Thin calcifications, thin septations. Class 2F, hyperdense, greater than 3 cm. Minimally thickened calcifications, 5% chance cancer. Class 3, thick septations, mural nodule, 50% chance cancer. Class 4, any enhancement, 15 HU. Class 1, Class 2, Class 2F, Class 1, Class 2, Class 2F. F. Simple anechoic hyperdense, less than 3 cm, hyperdense, greater than 3 cm, 0% chance of CA. Thin calcifications. Class 3, thick calcifications. Mural nodule. Thin septations, less than 5% chance of CA minus 50% chance of CA. 0% chance of CA. Class 4, any enhancement minus 100% chance of CA. Hyperdense cysts. Basically, if the mass is greater than 70 HU and homogeneous, it's benign, hemorrhagic or proteinaceous cyst, 99.9% of the time. Autosomal dominant polycystic kidney disease, ADPKD, kidneys get progressively larger and lose function. You get dialysis by the 5th decade. Hyperdense contents and calcified wall are frequently seen due to prior hemorrhage. What you need to know is, 1. It's autosomal dominant ADPKD. 2. They get cysts in the liver 70% of the time. 3. They get seminal vesicle cysts, some sources say 60%, and 4. They get berry aneurysms. As mentioned before, they don't have an intrinsic risk of cancer, but do get cancer once they are on dialysis. Autosomal recessive polycystic kidney disease, ARPKD, these guys get HTN and renal failure. The liver involvement is different than the adult form. Instead of cysts, they have abnormal bile ducts and fibrosis. This congenital hepatic fibrosis is always present in ARPKD. The ratio of liver and kidney disease is inversely related. The worse the liver is, the better the kidneys do. The better the liver is, the worse the kidneys are. On ultrasound, the kidneys are smoothly enlarged and diffusely echogenic, with a loss of corticomedullary differentiation. Uremic cystic kidney disease. About 40% of patients with end-stage renal disease develop cysts. This rises with duration of dialysis in about 90% in patients after 5 years of dialysis. The thing to know is, increased risk of malignancy with dialysis, 3-6x. Trivia: the cysts will regress after renal transplant. 185. Von Hippel-Lindau autosomal dominant multisystem disorder. 50 to 75% have renal cysts. 25 to 50% develop RCC, clear cell. Pancreas, cysts, serous microcystic adenomas, neuroendocrine, islet cell, tumor adrenal, pheochromocytoma, often multiple, CNS, Hemangioblastoma of the cerebellum, brain stem, and spinal cord. Tuberous sclerosis, autosomal dominant multisystem disorder. You have hematomas everywhere: brain, lung, heart, skin, kidneys. The renal findings are bilateral multiple angiomyolipomas. They also have renal cysts, and occasionally RCC, same rate as general population, but in younger patient population. With regard to other organ systems, lung LAM thin-walled cysts and chylothorax cardiac rhabdomyosarcoma typically involve cardiac septum, brain giant cell astrocytoma, cortical and subcortical tubers, subependymal nodules, renal AMLs, RCC, in younger patients. Lithium nephropathy occurs in patients who take lithium long-term. Can lead to diabetes insipidus and renal insufficiency. The kidneys are normal to small in volume with multiple, innumerable, tiny cysts, usually 2 to 5 millimeters in diameters. These microcysts are distinguishable from larger cysts associated with acquired cystic disease of uremia. They are probably going to show this on MRI with a history of bipolar disorder. ADPKD cysts in liver, IVHL cysts in pancreas. Kidneys are BLG. Acquired lion, S are small, your IC. 186. Multicystic dysplastic kidney. This is a PEDS thing, where you have multiple tiny cysts forming in utero. What you need to know: 1. That there is no functioning renal tissue. 2. Contralateral renal tract abnormalities occur like 50% of the time. MCDK versus bad hydro? In hydronephrosis, the cystic spaces are seen to communicate. In difficult cases, renal scintigraphy can be useful. MCDK will show no excretory function. Peripelvic cyst versus parapelvic cyst. Peri originates from renal sinus, mimics hydropara, originates from parenchyma, may compress the collecting system. T2 dark renal cyst. Cysts are supposed to be T2 bright. If you see the T2 dark cyst, then you are dealing with the classic differential of 1. Lipid poor AML. A small percentage of AMLs are lipid poor in the general population. For the purpose of multiple choice, if you see a lipid poor AML, especially if you see a bunch of them, you need to think about tuberous sclerosis. About 30% of their AMLs are lipid poor. 2. Hemorrhagic cyst. These will likely be T1 bright. 3. Papillary subtype RCC. Remember that clear cells, the most common subtype, are T2 hyperintense. Both clear cell and papillary will enhance, but the clear cell enhances more avidly, equal to cortex on corticomedullary phase. 187. SECR10N4 infections. Pyelonephritis. This is a clinical diagnosis. However, you do end up diagnosing it. It's associated with stones. The most common organism is E. coli. In acute bacterial nephritis, alternating bands of hypo and hypertenuation, striated nephrogram, are seen. These wedge-shaped areas are related to decreased perfusion. Perinephric stranding is also commonly seen. Striated nephrogram DDX. Acute ureteral obstruction, acute pyelonephritis, medullary sponge kidney, acute renal vein thrombosis, radiation nephritis, acutely following renal contusion, hypotension, bilateral, infantile polycystic kidney, bilateral. Abscess pyelo may be complicated by abscess, which can present on CT as round or geographic low attenuation collections that do not enhance centrally, but do have an enhancing rim. Bigger than 3 centimeters, and these guys might visit the IR section for drainage. Chronic pyelonephritis, sort of a controversial entity. It is not clear whether the condition is an active chronic infection, arises from multiple recurrent infections, or represents stable changes from a remote single infection. The imaging findings are characterized by renal scarring, atrophy, and cortical thinning, with hypertrophy of residual normal tissue. Basically, you have a small deformed kidney, with a bunch of wedge defects, and some hypertrophied areas. Emphysematous pyelonephritis. This is a life-threatening necrotizing infection characterized by gas formation within or surrounding the kidney. What you need to know: 1. It's really bad. 2. Diabetics almost exclusively get it. 3. Echogenic foci with dirty shadowing on ultrasound. Emphysematous pyelonephritis. This is less bad relative to emphysematous pyelonephritis. The gas is localized to the collecting system. It's more common in women, diabetics, and people with urinary obstruction. Radiographic finding is gas outlining the ureters and dilated calyces. Emphysematous pyelonephritis 188. Pyonephrosis, an infected or obstructed collecting system, which is frequently enlarged. Can be from a variety of causes: stones, tumor, sloughed papilla secondary to pyelonephritis. Can totally jack your renal function if left untreated. Fluid level in the collecting system can be seen on US CT. Has trouble telling the difference between hydro and pyonephrosis. Xanthogranulomatoous pyelonephritis, XGP, chronic destructive granulomatous process that is basically always seen, with a Staghorn stone acting as a nidus for recurrent infection. You can have an associated Psoas Abscess with minimal perirenal infection. It's an ant mini, with a very characteristic bear paw appearance on CT. The kidney is not functional, and sometimes nephrectomy is done to treat it. Xanthogranulomatoous pyelonephritis, bear paw. Papillary necrosis. This is ischemic necrosis of the renal papillae, most commonly involving the medullary pyramids. Diabetes is the most common cause. Other important causes include pyelonephritis, especially in kids, sickle cell, TB, analgesic use, and cirrhosis. Filling defects might be seen in the calyx. The appearance of a necrotic cavity in the papillae with linear streaks of contrast inside the calyx has been called a lobster claw sign. Trivia: 50% of sickle cell patients develop papillary necrosis. 189. TB. The most common extrapulmonary site of infection is the urinary tract. There are features of papillary necrosis and parenchymal destruction. You can have extensive calcification. Basically, you end up with a shrunken, calcified kidney, putty kidney. This end-stage appearance is essentially an autonephrectomy. The Kerr kink is a sign of renal TB with scarring leading to a sharp kink at the pelviureteric junction. Renal sinus fat appearance has also been described. It's edema in the fat, rather than loss of the actual fat. Disseminated PCP in HIV patients can result in punctate, primarily cortical, calcifications. Contrast-induced nephropathy, CIN. The more you read about the cysts are supposed to be T2 bright. If you autosomal dominant polycystic kidney disease, ADPKD, kidneys get progressively larger and lose function. You get dialysis by the 5th decade. Hyperdense contents and calcified wall are frequently seen due to prior hemorrhage. What you need to know is: 1. It's autosomal dominant ADUJT. 2. They get cysts in the liver 70% of the time. 3. They get seminal vesicle cysts, some sources say 60%, and 4. They get berry aneurysms. As mentioned before, they don't have an intrinsic risk of cancer, but do get cancer once they are on dialysis. Autosomal recessive polycystic kidney disease, ARPKD, these guys get HTN and renal failure. The liver involvement is different than the adult form. Instead of cysts, they have abnormal bile ducts and fibrosis. This congenital hepatic fibrosis is always present in ARPKD. The ratio of liver and kidney disease is inversely related. The worse the liver is, the better the kidneys do. The better the liver is, the worse the kidneys are. On ultrasound, the kidneys are smoothly enlarged and diffusely echogenic, with a loss of corticomedullary differentiation. Uremic cystic kidney disease: about 40% of patients with end-stage renal disease develop cysts. This rises with duration of dialysis in about 90% in patients after 5 years of dialysis. The thing to know is, increased risk of malignancy with dialysis, 3-6x. Trivia, the cysts will regress after renal transplant. 185. Von Hippel-Lindau autosomal dominant multisystem disorder. 50 to 75% have renal cysts. 25 to 50% develop RCC, clear cell. Pancreas, cysts, serous microcystic adenomas, neuroendocrine, islet cell, tumor adrenal, pheochromocytoma, often multiple. Multiple, CNS, hemangioblastoma of the cerebellum, brainstem, and spinal cord. Tuberous sclerosis autosomal dominant multisystem disorder. You have hemartomas everywhere, brain, lung, heart, skin, kidneys. The renal findings are bilateral multiple angiomyolipomas. They also have renal cysts, and occasionally RCC, same rate as general population, but in younger patient population. With regard to other organ systems, lung LAM thin-walled cysts and chylothorax cardiac rhabdomyosarcoma typically involve cardiac septum, brain giant cell astrocytoma, cortical and subcortical tubers, subependymal nodules renal AMLs, RCC, in younger patients. Lithium nephropathy occurs in patients who take lithium long-term. Can lead to diabetes insipidus and renal insufficiency. The kidneys are normal to small in volume with multiple, innumerable, tiny cysts, usually 2 to 5 millimeters in diameters. These microcysts are distinguishable from larger cysts associated with acquired cystic disease of uremia. They are probably going to show this on MRI with a history of bipolar disorder. ADPKD cysts in liver, IVHL cysts in pancreas. Kidneys are BLG. Acquired lion, S are small, your IC. 186. Multicystic dysplastic kidney. This is a PEDS thing, where you have multiple tiny cysts forming in utero. What you need to know, 1, that there is no functioning renal tissue, 2, contralateral renal tract abnormalities occur like 50% of the time. MCDK versus bad hydro? In hydronephrosis, the cystic spaces are seen to communicate. In difficult cases, renal scintigraphy can be useful. MCDK will show no excretory function. Peripelvic cyst versus parapelvic cyst. Peri originates from renal sinus, mimics hydropara, originates from parenchyma, may compress the collecting system. T2 dark renal cyst. Cysts are supposed to be T2 bright. If you see the T2 dark cyst, then you are dealing with the classic differential of 1. Lipid poor AML. A small percentage of AMLs are lipid poor in the general population. For the purpose of multiple choice, if you see a lipid poor AML, especially if you see a bunch of them, you need to think about tuberous sclerosis. About 30% of their AMLs are lipid poor. 2. Hemorrhagic cyst. These will likely be T1 bright. 3. Papillary subtype RCC. Remember that clear cells, the most common subtype, are T2 hyperintense. Both clear cell and papillary will enhance, but the clear cell enhances more avidly, equal to cortex on corticomedullary phase. 187. SECR10N4 infections. Pyelonephritis. This is a clinical diagnosis. However, you do end up diagnosing it. It's associated with stones. The most common organism is E. coli. In acute bacterial nephritis, alternating bands of hypo and hypertenuation, striated nephrogram, are seen. These wedge-shaped areas are related to decreased perfusion. Perinephric stranding is also commonly seen. Striated nephrogram DDX. Acute ureteral obstruction, acute pyelonephritis, medullary sponge kidney, acute renal vein thrombosis, radiation nephritis, acutely following renal contusion, hypotension, bilateral, infantile polycystic kidney, bilateral. Abscess pyelo may be complicated by abscess, which can present on CT as round or geographic low attenuation collections that do not enhance centrally, but do have an enhancing rim. Bigger than 3 centimeters, and these guys might visit the IR section. Section for drainage. Chronic pyelonephritis, sort of a controversial entity. It is not clear whether the condition is an active chronic infection, arises from multiple recurrent infections, or represents stable changes from a remote single infection. The imaging findings are characterized by renal scarring, atrophy, and cortical thinning, with hypertrophy of residual normal tissue. Basically, you have a small deformed kidney, with a bunch of wedge defects, and some hypertrophied areas. Emphysematous pyelonephritis. This is a life-threatening necrotizing infection characterized by gas formation within or surrounding the kidney. What you need to know: 1. It's really bad. 2. Diabetics almost exclusively get it. 3. Echogenic foci with dirty shadowing on ultrasound. Emphysematous pyelitis. This is less bad relative to emphysematous pyelonephritis. The gas is localized to the collecting system. It's more common in women, diabetics, and people with urinary obstruction. Radiographic finding is gas outlining the ureters and dilated calyces. Emphysematous pyelonephritis 188. Pyonephrosis, an infected or obstructed collecting system, which is frequently enlarged. Can be from a variety of causes: stones, tumor, sloughed papilla secondary to pyelonephritis. Can totally jack your renal function if left untreated. Fluid level in the collecting system can be seen on US CT. Has trouble telling the difference between hydro and pyonephrosis. Xanthogranulomatoous pyelonephritis, XGP, chronic destructive granulomatous process that is basically always seen, with a Staghorn stone acting as a nidus for recurrent infection. You can have an associated Psoas Abscess with minimal perirenal infection. It's an ant mini, with a very characteristic bear paw appearance on CT. The kidney is not functional, and sometimes nephrectomy is done to treat it. Xanthogranulomatoous pyelonephritis, bear paw. Papillary necrosis. This is ischemic necrosis of the renal papillae, most commonly involving the medullary pyramids. Diabetes is the most common cause. Other important causes include pyelonephritis, especially in kids, sickle cell, TB, analgesic use, and cirrhosis. Filling defects might be seen in the calyx. The appearance of a necrotic cavity in the papillae with linear streaks of contrast inside the calyx has been called a lobster claw sign. Trivia: 50% of sickle cell patients develop papillary necrosis. 189. TB. The most common extrapulmonary site of infection is the urinary tract. There are features of papillary necrosis and parenchymal destruction. You can have extensive calcification. Basically, you end up with a shrunken, calcified kidney, putty kidney. This end-stage appearance is essentially an autonephrectomy. The Kerr kink is a sign of renal TB with scarring leading to a sharp kink at the pelviureteric junction. HIV nephropathy, normal-sized, or big, kidneys that are echogenic on US. Loss of the renal sinus fat appearance has also been described. It's edema in the fat, rather than loss of the actual fat. Disseminated PCP in HIV patients can result in punctate, primarily cortical, calcifications. Contrast-induced nephropathy, CIN. The more you read about this, the more you realize it's probably complete, or at least near complete, bullshit. But some academic people have made a career on it, so we have to treat it like it's a real thing. In your abundant free time, read this paper and become enlightened. I will warn you. If you are a follower of conventional wisdom, you think books need to be published under a conventional publisher to be legitimate, you think screening mammography improves mortality, or you think the NSA is protecting you by recording all your cell phone conversations, this paper may make you cry. Davenport, Matthew S. ETAL. The challenges in assessing contrast-induced nephropathy. Where are we now? American Journal of Röntgenology 202.4. 2014 784 to 789. Trivia to know: allergic reactions are not considered a risk factor for CIN. Risk factors for CIN include pre-existing renal insufficiency, diabetes mellitus, even more so with pre-existing renal insufficiency, cardiovascular disease with CHF, dehydration, and myeloma hydration via 4 with 0.9% normal saline 6 to 12 hours before, and continuing 4 to 4 to 12 hours after contrast administration supposedly decreases the incidence of CLN in patients with chronic renal insufficiency. True mechanism is diluting CR levels. Oral hydration has been shown to not work as well. 190. SECR10NS calcifications. Nephrolithiasis, kidney stone. Stones. There are several different stone types. The most likely testable trivia for each is calcium oxalate, by far the most common type, 75%. Struvite stone, more common in women, and associated with UTI, uric acid - unseen on X-ray. Cystine, rare and associated with congenital disorders of metabolism. Indinavir stones in HIV patients, which are the only stones not seen on CT. Treatment trivia. There are two pieces of trivia that matter with regard to treatment. Size matters. Stones measuring 5 mm or smaller have a high likelihood of spontaneous passing. Stones measuring LCM or larger have a high likelihood of not passing spontaneously. Composition: uric acid versus not uric acid. Uric acid stones very rarely will require any kind of invasive intervention, lithotripsy, etc. The reason is they are very pH dependent. Big fat people and/or diabetics tend to have more acidic urine, from Augie that Mountain Dew, which leads to an increase in uric acid stones. They can be treated with medical therapy, potassium citrate, or sodium bicarbonate, to increase the pH and melt the stones. You can't melt a calcium stone by messing with the pH. Diagnosis of uric acid stones. Since identification of a uric acid stone is going to change management, that makes it a target for trivia on multiple choice. There are two things that I would know. 1. Uric acid stones tend to have lower attenuation, 500 HU. 2. Uric acid stones will have little if any change in HU with dual energy CT. The reason is they are composed of light elements. The larger atoms, calcium, phosphorus, magnesium, and sulfur, tend to have a larger change, which is the basis of dual energy CT, 80 kV, and 140 kV, identification of stone composition. Trivia: non-uric acid stones will have higher HU at 80 kVp relative to to 140 kVp. Trivia: uric acid stones will be very similar to 80 kVp relative to 140 kVp. Asterisk: if they do show a small change, it will be the opposite, with a slightly higher HU at 140 kVp. Trivia: calcium stones are going to show the biggest HU change between high and low energies. In general, low/high energy ratios are going to be around 1.1 for uric acid, 1.25 for cysteine, and 1.25 for calcium. 191. Cortical nephrocalcinosis. This is typically the sequela of cortical necrosis. WHLCH can be seen with an acute drop in blood pressure, shock, postpartum, burn patients, etc. It starts out as a hypodense non-enhancing rim that later develops THLN calcifications. Mimic is disseminated PCP. Medullary nephrocalcinosis. Hyperechoic renal papilla, pyramids, which may or may not shadow. There are multiple causes. The most common of WHLCH is probably hyper-PTH. A few texts say medullary sponge kidney is most common. Other things to think about include Lasix use in a child, renal tubular acidosis, distal subtype or type by medullary sponge kidney if asynonetric. RTA and hyperparathyroid usually cause a more dense calcification than medullary sponge kidney. Medullary nephrocalcinosis. Hyperechoic pyramids that shadow. Medullary sponge kidney. A congenital cause of medullary nephrocalcinosis, usually asymmetric. The underlying mechanism is a cystic dilation of the collecting tubules of the kidney, so the testable association with Ehlers-Danlos makes sense. The association with Carrelli-Sorda makes sense. The association with Beckwith-Weidman doesn't really make sense, and therefore is the most likely to be tested. Think about medullary sponge kidney with unilateral medullary nephrocalcinosis. Page kidney sequela of long-standing compression of the kidney by some kind of subcapsular collection, hematoma, or seroma. The classic scenario is post-lithotripsy subcapsular hematoma, with follow-up showing a shrunk-up kidney. 192. This versus that, delayed versus persistent nephrogram. Delayed nephrogram, one kidney enhances, and the other doesn't, or does to a lesser degree. Basically, this is happening from pressure on the kidney, either extrinsic from a page kidney situation, or intrinsic from an obstructing stone. Persistent nephrogram. This is seen with hypotension/shock and ATN. They can show this several ways. One would be on a plain film of the abdomen, with dense kidneys. The second would be on CT. The tip-offs are going to be that they tell you the time, 3 hours, etc., and it's gonna be bilateral. Delayed nephrogram. Renal infarct. So wedge-shaped hypodensities in the kidney can be seen with lots of stuff, infarct, tumor, infection, etc. Renal infarcts are most easily identified on post-contrast imaging in the cortical phase. If the entire renal artery is out, well then it won't enhance, duh. Two tricks that they could pull are the 1. Cortical rim sign, which is absent immediately after the insult, but is seen 8 hours to days later. You have a dual blood supply, which allows the cortex to stay perfused. 2. Flip-1 flop enhancement can be seen, where a region of hypodensity, at poor enhancement, on early phases becomes relatively hyperdense on delayed imaging. Persistent nephrogram. Renal vein thrombosis. Numerous causes including dehydration, indwelling umbilical venous catheters, most common in neonates, and nephrotic syndrome, most common in adults. This can mimic a renal stone, presenting with flank pain, an enlarged kidney, and a delayed nephrogram. On Doppler they are going to show you reversed arterial diastolic flow and absent venous flow. Asterisk. This is discussed again below in the transplant section. 193. SECR10N6 trauma. Obviously the kidney can get injured in trauma, seen in about 10%. Injury can be graded based on the presence of hematoma-laceration-involvement of the vein, artery, or UPJ obstruction. Gamesmanship. A good next step type question in the setting of renal trauma, or pelvic fracture, would be to prompt you to get delayed imaging. This is helpful to demonstrate a urine leak. Terminology. Fractured kidney. A laceration, which extends the full length of the renal parenchyma. By definition, the laceration must connect two cortical surfaces, so think about it going all the way through. Shattered kidney. This is a more severe form of a fractured kidney. A kidney with 3 or more fragments. This is the most severe form of renal fracture. Wedge-shaped perfusion abnormality. Think segmental artery injury. Injury. Renal trauma. Rapid pearls. Diffuse non-perfusion. Think devascularized kidney. Persistent nephrogram. Think renal vein injury. Thrombosis. 194. SEC110N1 transplant. Renal transplant is the best treatment for end-stage renal disease, and the quality of life is significantly better than that of a long-term dialysis patient. The transplanted kidney is most commonly placed in the extraperitoneal iliac fossa, so that the allograft can be anastomosed with the iliac vasculature and urinary bladder. Normal. A transplant kidney is just like a native kidney. It should have low resistance. It's always on. The upstroke should be brisk, and the flow in diastole forward. Remember, it's always on. Significance of RIS. If the meat of the kidney becomes sick from whatever the cause might be, rejection, infection, inflammation, etc., it starts to increase resistance. This increased resistance raises URT. The higher the RL, the sicker the kidney. This is why RLS are useful, and this is why an upward trend in RI is worrisome. RLs should stay below 0.7. Higher than that should trigger you to think something is wrong. You can think of complications in 3 main flavors: A. Urologic, B. Vascular, C. Cancer. Urologic complications. Urinoma. This is usually found in the first 2 weeks post-OP. Urine leak, or urinoma, will appear as an anechoic fluid collection, with no septations, that is rapidly increasing in size. MAG3 nuclear medicine scan can be used to demonstrate this, or the cheaper ultrasound. Hematoma common immediately post-OP usually resolves spontaneously. Large hematoma can produce hydro. Acute hematoma will be echogenic, and this will progressively become less echogenic, with older hematomas more anechoic and septate. Lymphoceles typically occur 1 to 2 months after transplant. They are caused by leakage of lymph from surgical disruption of lymphatics. The fluid collection is usually medial to the transplant, between the graft and the bladder. They are actually the most common fluid collection to cause transplant hydronephrosis. Buzzword equals ipsilateral lower extremity edema from femoral vein compression. Acute rejection IATN. Up to 20% of transplant patients will have some early rejection. Both ATN and acute rejection tend to occur in the first week or so. On ultrasound, the pyramids become prominent, the transplant itself gets bigger, and the RLS go up. ATN versus acute rejection is best distinguished on MAG3, where the ATN has normal perfusion, and the rejection does not. Both will have delayed excretion. Chronic rejection. This occurs 1 year post-transplant. The kidney may enlarge, and you can lose corticomedullary differentiation. The RLS will elevate 0.7, which is nonspecific. Calculus disease. Compared with the general population, transplant kidneys are at increased risk of stone formation. 195. Vascular complications. Renal vein thrombosis typically seen within the first week. Typically the kidney is swollen. Instead of showing you the Doppler of the renal vein, which would show no flow, they will most likely show you the artery, which classically has reversed diastolic flow. Renal vein thrombosis with the artery showing reversal of diastolic flow. Some people call this the reverse M sign. Reverse diastolic flow. Renal artery thrombosis usually seen within the first month. Typically caused by kinking, hypercoagulation, or hyperacute rejection. Delayed, late, thrombosis is often due to stenosis. Renal artery stenosis typically seen within the first year after transplant, usually weeks to months. Occurs in 5 to 10% renal transplants, which makes it the most common vascular complication of transplant. This usually occurs at the anastomosis, especially end-to-end types. The clinical scenario buzzword is going to be refractory hypertension. Criteria include PSV 200 to 300 EMFs. PSV ratio 3.0, external iliac artery IRA, tardus parvus, measured at the main renal artery hilum, not at the arcuates, anastomotic Jennings. Arteriovenous fistula, AVF, these occur secondary to biopsy. They occur about 20% of the time post-biopsy, but are usually small and asymptomatic. They will likely show it with tissue vibration artifact, paravascular, mosaic color assignment due due to tissue vibration. Vibration with high arterial velocity and pulsatile flow in the vein. Pseudoaneurysm. These also occur secondary to biopsy, but are less common. They can also occur in the setting of graft infection or anastomotic dehiscence. They will most likely show you the classic yin-yang color picture. Alternatively, they could show Doppler with a biphasic flow at the neck of the pseudoaneurysm. 196. Cancer in the transplant. The prolonged immunosuppression therapy that renal transplant patients are on places them at significantly 1x increased risk of developing cancer. RCC increased risk, with most of the cancers, 90%, actually occurring in the native kidney. Etiology is not totally understood. Maybe it's the immunosuppression, or the fact that many transplant patients were on dialysis, a known risk factor that leads to the cancer risk. In reality, it doesn't matter, and is probably both. Post-transplant lymphoproliferative disorder, PTLD. This is an uncommon complication of organ transplant associated with B-cell proliferation. It is most common in the first year post-transplant and often involves multiple organs. The treatment is to back off the immunosuppression. Cyclophosphamide is a point of trivia. Significant exposure to cyclophosphamide, just common now with the development of cyclosporin A, is associated with increased risk of urothelial cancer. Week 1 renal vein thrombosis, urinoma, hematoma. Weeks 1 to 4 renal artery thrombosis, lymphocytic. Months 1 to 6 renal artery stenosis, common, lymphocytic. Biopsy-related injury, pseudoaneurysm, AV fistula, drug toxicity. After 6 months, chronic rejection. RCC. L-lymphoma. PTLD. 197. SEC 110 NA ureters. Normal anatomy. The ureters run anterior to the psoas muscle and empty at lateral angles of the bladder trigone. They have 3 layers, with the inner layer being transitional epithelium. Developmental ureter anomalies. Congenital, primary, MEG. This is a wastebasket term for an enlarged ureter, which is intrinsic to the ureter, as opposed to the result of a distal obstruction. Causes include 1. Distal adenamic segment, analogous to achalasia, or colonic Hirschsprungs. 2. Reflux at the UVJ. 3. It just wants to be big, totally idiopathic. The distal adenamic type obstructing primary megareader can have some hydro, but generally speaking an absence of dilation of the collecting system helps distinguish this from an actual obstruction. Most cases just have dilation of the lower 1/3. It is almost always unilateral, favoring the left side. Retrocaval ureter, circumcaval, although the name implies that this is the result of a maldeveloped ureter. Ureter, it's actually a developmental anomaly of the IVC. Most of the time it's asymptomatic, but can cause partial obstruction and recurrent UTI. IVP will show a reverse J or fishhook appearance of the ureter. Duplicated system. The main thing to know about duplicated systems is the so-called Weigert-Meyer rule, where the upper pole inserts inferior and medially. The upper pole is prone to ureterocele formation and obstruction. The lower pole is prone to reflux. Upper, lower, I. 0 Weigert-Meyer rule. Upper pole inserts medial and inferior. 198. Ureterocele. A cystic dilation of the intravesicular ureter, secondary to obstruction at the ureteral orifice. IVP will show the cobra head sign, with contrast surrounded by a lucent rim, protruding from the contrast-filled bladder. This is associated with a duplicated system, specifically the upper pole. Ureteroceles are best demonstrated during the early filling phase of the VCUG. There is a picture of this in the PEDS chapter, page 51. Pseudoaneurysm. This is an acquired dilation of the submucosal portion of the distal ureter. A loss of the normal lucent line around the cobra head suggests a pseudoaneurysm. Causes include an impacted stone, a recently passed stone, and a bladder malignancy. Ectopic ureter. The ureter inserts distal to the external sphincter in the vestibule. More common in females and associated with incontinence, not associated with incontinence in men. Vesicoureteral reflux refers to retrograde flow of urine. The supposed malfunction is that the course of the ureter is too short as it crosses the bladder, messing with the ureteral valve mechanism. This is really a PEDS thing, and discussed more in the PEDS chapter. Congenital Upg obstruction. This is the most common congenital anomaly of the GU tract in neonates. About 20% of the time, these are bilateral. Most, 80%, of these are thought to be caused by intrinsic defects in the circular muscle bundle of the renal pelvis. Treatment is a pyeloplasty. A radiologist can actually add value by looking for vessels crossing up J prior to pyeloplasty, as this changes the management. Things to know about UpJ obstruction. Most common congenital anomaly of the GU tract associated with crossing vessels. Early branching lower pole vessels compress the ureter, associated with multicystic dysplastic kidney on the other side. 197, called. They want to know how to tell the difference between a prominent extrarena/pelvis versus a congenital UpJ obstruction. The answer is a Whittaker test, which is a urodynamic study combined with antegrade pie/ogram. 199. Ureter infection Lymphation. Stones tend to lodge in 3 spots: UPJ, UVJ, pelvic brim. Ureteral wall calcifications. Wall calcifications should make you think about 2 things: 1, TB, 2, schistosomiasis. Ureteritis cystica. Numerous tiny subepithelial fluid-filled cysts within the wall of the ureter. The condition is the result of chronic inflammation, from stones, chronic and/or infection. Typically this is seen in diabetics with recurrent UTI. There may be an increased risk of cancer. Ureteral pseudodiverticulosis. This is similar to ureteritis cystica, in that both conditions are the result of chronic inflammation, stones, infection. Instead of being cystic filling defects, these guys are multiple small outpouchings. They are bilateral 75% of the times, and favor the upper and middle third. There is an association with malignancy. Leukoplakia. This is essentially squamous metaplasia secondary to chronic irritations, stones or infections. The bladder is more commonly involved than the ureter. Imaging findings are unlikely to be shown, but would be mural filling defects. The question is most likely this: leukoplakia is considered premalignant, and the cancer is squamous cell. Trivia to know: leukoplakia is associated with squamous cell carcinoma, not transitional cell. Malakoplakia. This is also an inflammatory condition that occurs in the setting of chronic UTIs, highly associated with E. coli. It's often seen in female immunocompromised patients. This also has plaque-like or nodular intramural lesions, where bugs are incompletely digested. Since malakoplakia most frequently manifests as a mucosa, mass involving the ureter or bladder, the most common renal finding is obstruction secondary to a lesion in the lower tract. Step 1 buzzword equals Michaelis-Guttman bodies. Again, the bladder is more commonly affected. The question is most likely this: malakoplakia is not premalignant, and usually gets better with antibiotics. Just remember this. Leukoplakia equals premalignant. Malakoplakia equals not premalignant. 200. Retroperitoneal fibrosis. This condition is characterized by proliferation of aberrant fibro-inflammatory tissue, which typically surrounds the aorta, IVC, iliac vessels, and frequently traps and obstructs the ureters. It is idiopathic 75% of the time. Other causes include prior radiation, medications, methyldopa, ergotamine, methosergide, inflammatory causes, pancreatitis, pyelonephritis, inflammatory aneurysm, and malignancy, desmoplastic reaction, lymphoma. Things, trivia, you need to know. Mostly, 80%, idiopathic Orman disease associated with IgG4 disorders, autoimmune pancreatitis, Reed-Ells thyroiditis, inflammatory pseudotumor, classically shown with medial deviation of ureters. It's more common in non-malignancy-associated RP. Fibrosis occurs about 10% of the time. Some people advocate using PET to find a primary. The fibrosis will be gallium-avid, and PET hot in its early stages and cold in its late stages, mirroring its inflammatory stages. Metabolically active RP fibrosis will show increased FDG and gallium uptake, regardless of a benign or malignant underlying cause. Subepithelial renal pelvis hematoma. This tends to occur in patients on long-term anticoagulation. You are going to have a thickened upper tract wall, which is a classic mimic for TCC. They will have to show you pre- and post-contrast to show you that it's hyperdense on the pre-contrast and does not enhance. 201. Section 9. Lower tract cancer. Transitional cell carcinoma. This histologic subtype, makes up a very large majority, 90%, of the collecting system cancers. Imaging buzzword is goblet or champagne glass sign on CT-IVP. Risk factors: O. Smoking, O. Azodie, O. Cyclophosphamide, O. Aristolochic acid, Balkan nephropathy. Nephropathy see below, O. Horseshoe. Horseshoe kidney, O. Stones, O. Ureteral pseudodiverticulosis, O. Hereditary non-polyposis colon cancer, type 2. Some high-yield statistical trivia. Seriously, this is high-yield, O. Ureter, is the least common location for TCC of the urinary tract. O. TCC of the renal pelvis is 2x-3x times more common than ureter. O. TCC of the bladder is 1. OX times more common than ureter. O. In the ureter 75% of the TCCs are in the bottom 113. O. If you have upper tract TCC, there is a 40% chance of developing a bladder TCC. O. If you have bladder TCC, there is a 4% chance of developing a renal pelvis or ureteral TCC. O. Ureteral TCC is bilateral 5%. Balkan nephropathy. This is some zebra degenerative nephropathy endemic to the Balkan states. The only reason I mention it is that it has a super high rate of renal pelvis and upper ureter TCCs. It's thought to be secondary to eating aristolochic acid, AA, in seeds of the Aristolochia clematis plant. Squamous cell. This is much less common than TCC, in the US anyway. The major predisposing factor is schistosomiasis. They both start with an S. Hematogenous metastasis mets to the ureters are rare, but can occur, GI, prostate, renal, breast. They typically infiltrate the periureteral soft tissues and demonstrate transmural involvement. Fibroepithelial polyp. This is a benign entity, which is usually located in the proximal ureter and produces a smooth, oblong, mobile defect on urography. 202. Deviation of the ureters. Classic this versus that. Medial deviation I wasting of TBC ureters. Lateral deviation of the ureters. Retroperitoneal fibro __retroperitoneal